on the island in 2020. 9:08. We're getting ready to jump over to this Data with Dr. Ann live stream with the Department of Public Health and Social Services. Guys, so yeah, mind your health. I'm going to share a little story, a personal story with you guys, and my brush with diabetes coming up here on the show. But we're just really standing by now, and we'll go to the Zoom.
Dr. Ann. I see Dr. Ann shaking her head. This is our inaugural press briefing. It's once a week, possibly every Thursday with Dr. Ann. I know we've been talking about doing this, but we finally found a day, something that will work with Dr. Ann's schedule as well. She's been very busy trying to gather all the data. And we've been getting a lot of questions in the media. So we're trying to get this going once a week type of thing so that, everybody has an opportunity to have some face time with Dr. Ann, get some questions out there. And she can also present some data on COVID-19. We do have also available for, in case you guys have other questions as well, Mr. Chima Mbakwem, and we did have a town hall last night. I don't know if you guys saw that for the judiciary and also the law enforcement community. So Dr. David is here, although she did present a really great presentation last night as well. But she's also here. I don't know if you want to make yourself available, Dr. David, but she's here as well. So she is the lead epidemiologist for the state epidemiological working group. I think I said that right. Unfortunately, I know I didn't give everybody enough time ahead of, I only told you guys this morning, so it was kind of a last minute plan, but going forward, as I mentioned, we do want to do this on a weekly basis around the same time, 9 a.m. Thursdays, but I will remind our media partners, and thank you for joining us this morning. If you can put in the chat box who will be representing your organization when we go to our round of questioning. So when we do our question Q&A portion, we will give everyone a chance to ask questions, one round and 2 questions each. And this is just in the interest of time. Dr. Ann is a busy woman, so we want her to be able to get back to work so she can compile all the data. Again, in the chat box, if you can just list your name and the organization that you represent. So let me give Dr. Ann share screen permission so she can go ahead and begin her presentation. All right, Dr. Ann, the floor is yours. Thank you.
Okay, and let me, good morning. Let me also say that these are also on our website, the SITREP. I'm going to start with the SITREP. This is on our website, and all of the other reports have been uploaded to the JIC. And we're looking for a place to put them in an easily accessible area on the public health website. I'm going to start here. This is yesterday's SITREP. As you can see, we are at almost 16,000 cases and more than 260,000 tests, along with approximately 210 deaths as of yesterday. So now I'm going to share some of the trends that we're seeing. And we reported this yesterday to the governor's office. And this is our testing rate and the positivity rate. And as you can see, we're averaging about 1,100 tests per day. The positivity rate has been hovering around 13% for the past, the past month. This is our cases by day over the past month. And as you can see, we are seeing a dip, but we're still over the 100 mark. And yesterday was 160 some, I think. So it's fluctuating. But we're still in a surge. It's more than 100 cases a day. We're not going to be calling this, we're not going to say we're out of a surge till we're below 25 cases per day. This is the cases by age group. And as you can see, all the age groups are showing a decrease. We saw a really, really deep dip with the elderly beginning around the end of September, around the 23rd, 24th, but that has gone up again slightly. The largest group still is that 18 to 39 group and 40 to 59. These are working age parents, and they probably have a lot of exposure. We've also seen an uptick in the last 3 days with this 60 to 74 group. There's been an increase in symptomatic cases recently, and even though there's been an uptick, there's still more asymptomatic cases than symptomatic cases, which is actually a characteristic of Delta, but we really don't know how much Delta is circulating here. We haven't had any report on the variants recently since, I think, June. Breakthrough cases are averaging about 45% of the daily case rate, but the majority of the cases are still among the unvaccinated. And here's our fully vaccinated population at approximately almost 80%. Among the deaths, there have been 10 out of 81, or 12.3%, who are breakthrough cases. And all of those people are either elderly or people with multiple comorbidities. So the vaccine didn't help them, unfortunately. We are also seeing, this is the hospital cases over the past month. We're also seeing a dip in the hospital cases, but the ICU is clogged up with people. It's stagnant. It's been consistent like that for the past several weeks. And this was done the other day. We actually have 2 more deaths. We're at 210. The other thing we wanted to look at was breakthrough cases. And these are data as of the 17th of September. And as you can see, the breakthrough cases skew towards these younger age groups, and especially those under age 75. The lag time between people being fully vaccinated and getting a subsequent positive test or a breakthrough is skewing towards a 4-month interval. That's the average, but by age, we see that younger people have a shorter interval, and the elderly, I'm not sure why, they do not. So it could be that because this is our working age population here, that they have more chances for exposure. They're out in the community, they're working, they're doing things, and the elderly might be a little bit more protected. But again, the elderly represent a small portion of these breakthrough cases, as we noted earlier. Excuse me, this is a histogram for all the deaths, and as you can see, it skews heavily towards the elderly, especially those over 50. And I have one more screen to share, hang on. This is another report we did just the other day. We released this to the media the other day. We just discovered that, and it's not surprising, COVID is the leading cause of, in the top 10, it's number 3. It surpassed cardiovascular disease. Normally, we see disease of the heart first, cancer second, and then stroke. But COVID has surpassed stroke. It's number 3. We are on target, I believe, to still see COVID as the third leading cause of death for 2021. And I want to give a shout out to Cindy Naval. She's the one who put this together. We have a fetal death project with Cindy Naval. She's a retiree. Isn't that awesome? We have a retiree putting the top 10 causes of death together. She's been actually doing this for the past 20 years of data, and hopefully we'll have a report on that. This is what it looks like. And I believe there's one more. This should be 113. We had one missing before. Most people are getting a cause of death listed as COVID-19, and then some are getting other causes of death. I reported on this on a report I did a couple weeks ago on comorbidities. That's available on the JIC. It's a little more detailed. It's not just the top 10 causes of death. And if you look at what we normally see, this is 2019, the top 10 causes of death. Again, diseases of the heart, cancer, stroke. And the rest of these fluctuate between, they move around a little bit. The top three are the key diagnoses, causes of death, sorry. Diabetes is still up there, chronic liver disease, influenza, etc. So we're on track for this to be, for 2 years in a row, top 10 causes of death. Number 3, COVID. That's it for today. I'll take questions.
Thank you, Dr. Ann. And I will get those slides from Dr. Ann and share that with everyone here, all our media partners. So we'll go ahead and begin with our question and answer portion. And again, if you can go ahead and type in the chat box your name and which media organization you represent if you haven't. So I'll begin with PNC. Either Don Sulat or Polly Suba. You may go ahead and ask your questions.
None for now, thank you.
Okay, thank you. Next, we have KUAM, and this is either Chris or Bree.
Good morning, Janella and Dr. Ann, Shima, I think Dr. Annette, David. I did want to go back to something that you'd mentioned, Dr. Ann, regarding that 13% positivity rate and the 25 cases per day to go to get us out of this surge. So we've been in the surge for several weeks now, and we haven't seen any further restrictions, and we're still seeing the triple-digit positive cases. So I'm just kind of wondering, what do we need to do differently to get down to this 25 cases per day to get out of this surge? Anyone?
Okay, I think what we should do to get down to the 25% is to follow public health recommendations of wearing your mask, getting vaccinated, and keeping safe distance. This has worked until we got the vaccines. That is also a layered protection for us. And we also have the monoclonal treatment, which is keeping people out of the hospital. I think the impactful thing about what we've done at the early stages of the virus is the adherence to those simple public health recommendations. And what that does is to stop transmission. What the numbers are showing is that we have transmission, and the only way for us to cut down transmission is to wear our mask, watch our distance, and also to wash our hands. So that is what we can do to really force down these numbers. Thank you.
Don't forget vaccination as well. That's going to be key. And we still have a ways to go to get the entire island protected with vaccination. And then also keep in mind that those of us who got the vaccine early on in the year in January, that's been 9 months. And so now that the boosters for the Pfizer are being disseminated, we really need to ensure that everyone whose turn it is to get the booster gets an opportunity to get that.
Okay, I'm sorry. I'm not sure I heard anything that what we should be doing differently, but be that as it may. I did wanted to go also talk about the variants and how we haven't received any new results. I think, Chima, you said it on the show before that we haven't been sending any for whatever reason it was. But Dr. Ann, weeks ago, I think you had also hinted that we might have that capability to do the genome sequencing on island at some point. I don't know if it's later this year. Is there any update to that?
I don't have an update, but we did order the machine. I believe it's just, I really don't know. Don't quote me on this. I don't have an update. But yes, the idea was so that we can do this ourselves. And yes, we actually have been sending samples to the CDC. The problem is the CDC hasn't provided any results to us recently.
I see. Since June?
That's correct. We keep waiting and waiting, but I guess they're busy.
Is there any indication that we have any the mu variant here on Guam? I know that we don't have any results, but is there any indication that it's here on Guam?
There's no way to do that if you don't have the genome
results?
sequencing.
Okay.
Thank you, Bree.
Thank you.
Next is Pacific Island Times, Joyce McClure.
You. I'm wondering what other things are done, for example, businesses.
Hi, Joyce, you're coming off low, your sound.
Okay, I'm sorry.
Okay, we'll come back to you, thank you. We'll go to PDN, Joe Titano.
Morning, Dr. Ann. Morning, everybody. You know what? This is a question for Dr. Ann. One thing I'm wondering about is, you know, those breakthrough cases. What is the kind of the comorbidity profile looking like for people who are getting those breakthrough cases? And also I know Dr. Berger said that the majority of breakthrough are so what does that look like? What kind of conditions are people having? And, you know, are these multiple conditions that people are having? Have diabetes, or, you know, do they have, you know, real severe cases?
I don't have data on the comorbidity of the cases, only the deaths. We haven't run that data, but it's skewing towards younger people. That means they probably recover. Most people have a mild infection, especially among younger people. So we haven't, there's just been a couple deaths where the person is younger. But again, everybody who has died who has been fully vaccinated is usually multiple.
And in terms of, you know, I know we're still looking at dead on arrival cases are kind of driving that up. Are these people, you know, I think something like 87% of them are having cardiac arrest. Are these people, are these people with heart disease? What exactly is causing that? Do we know at this point? And is Guam kind of standing out in that? Is that particularly peculiar for any area?
It's hard to say, because we do know that the dead on arrival cases, they're more than half of the recent deaths. It was about 50% last week. It's 52%. And out of those, yes, the majority have cardiac arrest, and they're 3/4 of those are testing positive the day they go into the hospital, so they don't even know they are sick. And again, the majority are skewing towards elderly, people with multiple and or severe comorbidities. So they don't know they're sick. Most are not vaccinated, and it could be they have underlying heart disease and they don't know that as well. There could be a lot of, we believe, uncontrolled hypertension. We saw that in Hawaii in the Filipino community and Micronesian community. So it might be people who don't know that they have a chronic condition, but maybe that's just how that manifests when you're elderly. Because as you saw, number one cause of death is still heart disease. So you might have somebody who died of cardiac arrest, but the underlying cause was complications from COVID as well as heart disease. So you would have an immediate cause of death and then an underlying cause of death and or a contributory cause of death.
Right, and tracking at that 50%, something like 50%, is that unusual? Are people seeing that stateside, or are we sort of special in that area on Guam?
I do not know. I just know that we noticed it during this surge. We had one dead on arrival in April, and then we started seeing them July 8th, and then it started to get really bad in August, and I noticed it. I do not know if the other states are seeing this kind of pattern, but it's Lillian, the head of the GMH, said we also saw a lot of dead on arrivals in the hospital back in December, but they weren't reporting that to us. This year we have a lot better notes from the hospitals if somebody's hospitalized, and we can get information a little better than we did last year. So, you know, I can't answer your question. I have no idea. I just noted that in this surge, this is what we're seeing.
They are seeing it in some other countries. In the Philippines, for example, it is a phenomenon that is widely recognized. And so in the Philippines, they actually recommend that families and households have a which helps to monitor the level of oxygen in your blood using a finger device. What can happen is, with COVID, your ability impaired, and so your oxygen levels can go down. Now, in somebody who has a pre-existing comorbidity like heart disease or cancer or anything like that, they may not be able to tolerate the lower oxygen, and that can precipitate the death. And not knowing that you have COVID will really not raise the red flag for you as the individual. So as Dr. Ann was saying, that is the profile of the happening in other countries.
Thank you, Joe.
All right, Janella, before you ask the next question, I just wanted to make some clarification on what Dr. Ann said about the genome sequencing result. I think I've mentioned that there was a dry ice challenge, with our couriers. That was briefly resolved 2 weeks ago. So on the 29th, we sent 60 samples to CDC, and we're hoping that we'll get another chance to send another batch next week. So for now, we don't have the results from the last batch we sent out to CDC, and we're hoping that the dry ice problem will be permanently resolved so that we can send out more results, more specimens, so that we'll be able to obtain the results and have more clarity on what is going on. Thank you.
Thank you, Chima. We'll go back to Pacific Island Times. Joyce McClure.
Yes, hi, thanks. I'm Zoom challenged this morning, it seems. Thank you. Can you hear me better now?
Yes, we can hear you better.
Okay. So I want to go for just 2 seconds into sort of ancillary areas in terms of prevention. And, just going out in the community myself into restaurants and such, I noticed that there is still a lot of failure to sanitize pens that are being shared and countertops and things of that sort. Also, I'm wondering about the reporting of businesses, small businesses like gymnasiums and such that are not potentially adhering to the governor's orders. So I personally reported someone the other day, and I'm wondering, I did get an email back saying that they were going to check into it. But I'm wondering how the department is handling, again, more of an extension in terms of aid and transmission.
So thank you for your question. I think you sent an email to DEH, and they responded and told you they'll follow up. And I think they are really following up on all those reports. And they keep coming, and we still try to deploy resources to make sure that those situations are taken care of. But I think the message has been out there, and the community will understand that first of all, it's a personal thing for you to prevent yourself from getting the virus. The responsibility is to make sure that you don't expose others to the virus. I think while we continue to promote, prevention, we also employ people to please adhere to help get our community back to where we are. Thank you.
Joyce, I also want to add that we've been sending the COVID-19 inspection reports as well as the sanitary inspection reports to the media on a weekly basis. This comes from the Division of Environmental Health. And so you'll actually see all the establishments that we've been inspecting on a weekly basis. And you'll see, so I don't know if you received those, but I do send it to Pacific Island Times as well. So if you're not receiving them, let me know and I can make sure that you're part of the list of organizations that receives that. Do you have a follow-up question, Joyce?
No, that's all. Thank you very much.
Sure, thank you. Next, we'll go to PNC Digital.
Thanks, Janella. This could any of the health officials or the doctors out there. There's a school of thought out there that that says because Guam already has a relatively high vaccination rate, if, or even better, not to lift restrictions and just let the virus run through its course and sort of so we can get herd immunity. What are your thoughts on that?
Doug, do you want to go first or do you want me to go?
Did you hear me?
Yes, we heard you. Yes.
Right. If you let the virus run its course, people will pay a price in terms of life. This virus is quite deadly, and there will be people who will die. The concept of herd immunity really came as an idea. So the idea is that you vaccinate enough of the population so that you have a critical mass who are not susceptible to an infection. The concept of herd immunity was never devised as a public health. So it describes this idea of having enough people who are not susceptible, but it was never meant as a strategy for public health. And the reason for that is because if you allow an infection to run through a population just so that you can get enough of your population immune, you are going to pay the price in the terms of deaths. I mean, what we are seeing now is even with our still people who are falling through the cracks and who are paying the price with their lives and with their health. A good way to do it, particularly if you have effective vaccines available, which we do, and the vaccines are freely and easily accessible, which they are. So I think for us, the key message has to be to try and convince every single person who remains unvaccinated to get the vaccine. Somebody asked earlier, is there anything new? Unfortunately, there are no new magic bullets for COVID, but we do have some pretty well-established interventions that do work, as Chima had mentioned and as Dr. Ann have mentioned. It's just that we have to stay the course and really put our efforts into ensuring every single person in our island is adhering to the proven interventions, and they are the vaccination, the mask mandates, the social distancing, and the hand hygiene.
And let me add to that. There's some epidemiologists who are now talking not about herd immunity, but herd protection. And the reason we want to get vaccinated is it prevents people from dying, as Dr. David just mentioned, and prevents severe hospitalization and severe illness. That's more of a protective effect.
And then,
Okay, thank you.
And to conclude, with what the two doctors stated is that what we should be wary of is new transmissions. New transmissions lead to new variants. We don't want mutation for the virus. We started off with the traditional more than 4 to 5 variants, and these all are caused because of new transmissions. So I think it is important, like Dr. David said, to vaccinate. Make sure you keep yourself safe, wear your mask, and let us work together as a community to stop new transmissions so that we don't have new variants. Thank you.
Thank you. Do you have a follow-up question, Jerry?
No, thank you, Janella. Thanks.
Thank you. Next, we'll go to Guam Daily Post, Oyalni Redekla.
Good morning, everyone. Can you hear me?
Yes, we can hear you.
Hi. So I did have a question kind of following up on that. First of all, when we talk about the big thing, right? Everyone's being told to get their booster shot if they need to. Anybody, the difference between the booster shot and the third shot, I think in the community, I've received a lot of questions from family members and friends. Who should get it? That's my first question.
Dr. David, you can take a go at this and then I'll support you.
All right.
Let's start to, yeah.
There are certain people whose immune systems are not as strong as healthy, normal people. And examples would be people who have cancer or who have congenital or acquired immunodeficiency syndromes, people who don't have a functioning spleen, or people who have to be, for any reason, on immunosuppressant drugs like steroids or these folks are not able to mount a full response to the vaccine. And so for these people who have these underlying conditions that impair their immune response, what is being recommended and what has been found is that a third shot following the second can help immune response to the virus. So in that case, you were giving the third shot to someone so that you can help their immune system, which is not functioning as well as it should, to reach the maximal state of protection. Now, the booster would be for folks who have had the vaccine, the full series, but have it's been a while. And over that time period, which right now it's being recommended 6 months or more, so over that time period, what happens, which is a natural phenomenon, is your initial titers of antibodies start to go down over time. And so after that period of, if you get a booster, in this case, that will help to accelerate or raise your antibody levels for protection, given that the pandemic continues to so I hope that helps to clarify the issue. Also remember that right now the booster for Pfizer, we do not yet have guidelines for boosters for Moderna or the Johnson & Johnson, although already put in its application to the FDA to approve the use of this vaccine for a booster. I hope.
Yeah. Thank you, Doc. And I just wanted to add that while we talk about the boosters and additional shots, I think the foundation is the initial doses of your vaccine. I think it's important that we, as a community, in line with what the government is promoting and public health and WHO and CDC, it's important for us to get our initial shots of all the vaccine series, and then with what Dr. David described, get the additional doses or get the booster shots, as at when due. But as a community, it's important for us to please get our initial vaccines to get that protection before we boost it. Thank you.
So to clarify, because the third shots for Moderna, and then you see the booster shot numbers for Pfizer. So the third shots, as you were saying, Dr. David, the third shots for Moderna, those, and I mean, do they work the same way in essence, the booster and the third shots? Okay. Thank you for that. And then I also did have a question because we've seen this promote for women who are pregnant, women who are nursing, and there's been, at least one doctor, the safety of vaccinations, for at least women who are pregnant. So, there's a question, I think, a real concern in the community of how safe it is for women who are pregnant, vaccinated. Can you just speak on that and maybe and kind of point people in the direction of where they can get information to reassure themselves if they're pregnant or their spouses or family members? members who are in this situation who maybe don't know what to do because, you know, if we've talked about this before, the bombardment of information, right?
I think I will take the first dig on that because, first of all, call the vaccine adverse event reporting system. And this is a system that is developed for anyone or any vaccine site that has any adverse event to be reported to CDC. When you report to CDC, they investigate all those cases to make sure that they have an account or an understanding of what those adverse events are, because this is what actually guides us in understanding the efficacy and the side effects of the CDC's recommendation for vaccine for pregnant women was actually published last week, and the Department of Public Health and Social Services actually sent out a physician advisory yesterday in line with that CDC recommendation. And that recommendation is actually well researched, and it actually explains the role of the medical provider in describing or discussing the vaccines with their patients. So I think the onus lies on the provider using the prescribed guidance from CDC to inform their patients on the vaccine efficacy. And then going back to the local situation that you just described, and what I said earlier, you know, there's a verifiable system where this information is loaded, and it is actually treated with a lot of attention. So I think those reports, we also look forward, you know, while we hear those reports, I think we should also avail that system to report that to the federal government. Thank you.
Yeah, can I also add, thank you for asking that question. It's a very relevant and timely question. So what do we know about pregnancy and COVID? So first thing is we know that pregnancy puts a woman at much higher risk of severe COVID and death as compared to a non-pregnant woman. So a pregnant woman has about twice the likelihood of developing severe COVID and about 70% the chance of dying from COVID as compared to someone who is not pregnant. So it's very important for pregnant women to really protect themselves from this virus. Secondly, what do we know about vaccine safety in pregnancy? That's a very important concern, right? And you have evidence from any number of levels. So first, from the original animal studies to develop these vaccines. When they did that, they did not find any safety concerns in the laboratory animals that were studied. Second, in the clinical trials for the vaccines, when they looked at the human volunteers who were in the clinical trials for Pfizer, for example, they had tens of thousands of volunteers. Of those who volunteered, there were 23 women who became pregnant while on the trial. And only one of the 23 suffered a fetal loss. So they unmasked her records to see what she had gotten, and it turned out she had gotten the placebo, not the vaccine. And then thirdly, to build on what Chima had mentioned, there are multiple safety monitoring systems in place in our country to look at, particularly in pregnant women. And right now, there are like over 200,000 cases already of pregnant women who have gotten the vaccine without any increase in safety effects. So the overwhelming evidence is that these vaccines are safe in pregnancy. Of course, women have to make this decision in conjunction with their physicians, but it's important for physicians to be promoting the right messages. And so you asked about what is a good reference. Go to the American College of Obstetrics and Gynecology. This is the academic, official academic organization in the US that oversees all obstetricians and gynecologists who are board certified. They have come out with a very strong position statement, encouraging all pregnant women to get the vaccine. And the vaccine protects not just them, but also potentially their unborn child. So the antibodies they create from the vaccine are passed on to the baby who is unborn and gives the baby protection once the baby is born. I think it's a very important consideration because we are seeing a rise in pediatric cases. And in fact, right now, there were 2 cases in the pediatric ICU at GMH with COVID. And it is very worrisome, and we have to do everything that we can to protect the children who, as you know, are still not eligible for the vaccine. And so the only protection that the children have is for everyone around them to be vaccinated. So it's sort of like creating a circle of protection around the children. You don't want any breaks in that circle, and the mothers, of course, are the most important part of that circle. So I hope that's helpful.
It is. Thank you. Thank you very much, Doc. Can we go back a little bit to the breakthrough cases? Dr. Ann, you had spoken about the multiple comorbidities, particularly of those who are dead on arrival. And I'm so sorry. I think Joe from PDN had asked the question or commented on how there's a cardiac arrest is a big part of that. So when we're looking at that phenomena, the hypoxia, how do those play together and to give us, what is it, 53% you said, of most recent cases being categorized as dead on arrival?
Yes, those half of the recent deaths have been dead on arrival, and usually there may or may not be any notes because the person is dead on arrival, but sometimes the fire department and the medics are able to get some information. You know, this person hasn't been feeling well the past couple of days, or they're dizzy, and then they find them unresponsive and call 911. That seems to be the typical story, that the person wasn't feeling well, and then a heart attack, and then that's it. That's pretty much all the information we're getting. Sometimes, most of the time, probably about 80% of those cases as dead on arrival. So we just don't know. These are people who the family might or might not say they haven't been feeling well, or sometimes they just find the person unresponsive. Call 911.
Thank you, Oya.
Sorry, can I just ask one more question, Janelle? Dr. Annette David, there was several months ago you had did a presentation and you talked about sort of the lack of access to health care as being an issue as we go, and that's sort of highlighted, if you will, by the current pandemic. Those who are dead on arrival, are they indicative of that sort of shortcoming, if you will, of our healthcare system in total, and the lack of access people have to getting preventative?
That's a really excellent question, but I think it's not lack of access in this case. It's lack of so these are folks who, for whatever reason, don't feel well, but have not gotten tested. And so they're not aware that it's not just a cold, it's actually the COVID virus, which can be quite devastating to your pulmonary system. So I think what we do, if you ask me, I've worked in global health, so I countries in our region. What I have to say is we are, in fact, in Guam, we are very blessed in the sense that testing is readily available on a daily basis. And as Dr. Ann was showing, we are doing upwards of 1,100 to 1,500 tests a day. If you look at that, that's about almost 1% of our population that we are testing every day. I don't think that you find that in many places, even in the US mainland. And then the vaccines, the monoclonal antibodies, these are all available to the public at no cost. You go to the Philippines, for every test that you get in COVID in the Philippines, you pay thousands of here. So I think our leadership has made the healthcare and the interventions like the vaccines and the monoclonal antibodies and the testing very easily available to our population. But, you know, the government can make that available to the individuals to take up the offer and to make use of the resources that are available. So it's a tool. What this shows is we really need to do a lot more outreach so that people who don't feel well, particularly if they have comorbidity, and get tested quickly. Because if you don't test, you won't know if you have the virus. And the tragic consequence of that is the DOA.
I think, Doc, in reference to what Doc said, access to care is just not about having access to clinics or to healthcare, but it also has to do with the person's health. As public health, what we've been able to do since the beginning of this pandemic is that we have a team of nurses that are like a strike team. And this strike team, what they do is that when we identify those places of need, this team actually goes to give support. Families at the beginning, and with what we're doing now, the department is actually working with mayors to actually provide access to testing, to monoclonal treatment for those who do not have either the information because they lack access to information, but we're using that avenue, you know, to reach those people that cannot be reached. And as public health, we understand this. And these hard-to-reach communities are primarily part of our community. And the reasons that make them hard to reach is just not, but also maybe lack of education or lack of access to information. But we are working as a team and in collaboration with DCID and our CDAS partners. We're actually working towards reaching these hard-to-reach areas and providing these interventions to them directly. So we have the Community Health Workers Grant, and part of the reason for that grant is for us to have that ability to identify those hard-to-reach communities and go up to them to provide need. So I think we've been doing that. We've been constantly doing that. We did that a few weeks ago in some. We've had successes in identifying new cases, and we're also working towards identifying more and providing them with testing and vaccination. So COVID has actually shown that there is a lot to do for those who lack access to care and those who lack information. This is just not a Guam problem, it's a universal problem, and like Dr. David stated, is a global problem that COVID has actually escalated, is working towards closing that gap. Thank you.
And can I just add to this conversation? I also think, along with Dr. David, that this is lack of awareness, because we remember 48% were not. Now, some of them were in the hospital, but some of them were also home and then, you know, had to go into the hospital because is that sick. There is this free treatment that's available. We've been trying to get the word out on the monoclonal antibody treatment, particularly for elderly people and again, people with comorbid conditions. The other thing that we're seeing with the dead on arrivals, 70% of them were male. Oh, men are, they don't like to go to the doctor, right? So pay attention to your elderly or middle-aged relatives and how they're doing, because there's, as Dr. David said, it's free. Right now, it's free. The testing, the vax, the monoclonal antibody treatment.
Yeah.
Thank you.
And, you know, Doctor, can we go back a little bit, Dr. Ann?
Sorry, Oya, I have to give others a chance. Oya. All right, we'll go to the link. Chris Burnett.
Thank you, Janella. Hi, Chima. Hi, Dr. Ann. Hi, Dr. Annette. I just had a question about the reporting of positives with public school students. I know that last week we didn't report any cases with public school students, and I had reached out to Superintendent John Fernandez and also the Catholic schools, and they said that they had been very busy kind of standing up a return to face-to-face instruction, and so the public health had got the results, but they weren't being reported. And we're aware of a number of student positive cases. We've even heard anecdotally of parents who are having to pick up their sick kids from school, take them to go get tested, and they're testing positive. That being said, we're in week 2 of a return to face-to-face, and we have yet to see a single public school student case be reported. Can you please explain what is the delay in this reporting, or what the new policy is in reporting these student positive cases? Because we definitely have confirmed with school personnel and teachers and staff that there have been a number of positive cases with school students.
Okay, I have Vince Campo here, and he can talk about this, about the reporting of results to the from the schools, because we're just now setting that up, that system. Hold on.
Okay, everyone. How can I address your concerns?
Sorry, Chris, can you repeat your question? Thank you.
Well, if you could just tell us why we're not seeing student positives being reported as we near 2 weeks after the start of face-to-face instruction, especially when we've heard of when we start over? Okay. Vince, can you hear me?
Yes, I can.
Good morning. Good morning. I just wanted to ask, what's the status of reporting student positives? Because we're aware that there were a number of student positives last week as well as this week, and we haven't seen public school cases reported.
So student positives, so that one's a little bit interesting. So the way that students are being reported positive is we have a couple of schools already onboarded for screening testing, right? But a lot of our student positives are really coming from the household exposures of what we're catching in the community and from our positive cases. So a lot of these are household exposures, so they're usually either quarantined full of time before we get them tested, right? So we don't test them right away. We give them 3 to 5 days, but we make sure that they are in quarantine. So a lot of these student positives would be coming from private clinics or ourselves at DPHSS. So you'd see them at the TZEN outreach, or you might see them at their respective primary physicians like AMC, ECC, things like that. Right now, so what we do is for the positives that are getting tested at the school, they are being reported on our reports. You can see those on our comprehensive SITREP reports on Fridays, which is updated on our dashboard and our website every Friday. So you can see that one there. And is there any other questions? Did I answer that question completely?
Hold on, because
Yeah, thank you, Vince. Thank you so much. Thank you for your time, Vince.
What's up?
Chima, did you want to answer that?
Yeah, Vince, did you say how many cases we've had?
I can't hear you. I can't hear.
Were you,
I can't hear the question.
Vince, did you say how many cases we've had? I'm sorry, I kind of missed the second half of your answer.
So I don't have the exact count of how many students per se, just because it is a very general, when they list it on the form, they just put students. So I couldn't even really tell you the difference between, I can't really tell the difference between the private schools and our public school students, but we do see that they are students, and we are looking at, the cases that are in the range of being, students, right? So of course, cases from 17 or 3 to 18. So we do have eyes on them, but not necessarily detailed data about what school they go to, if they're online or in person, and things like that.
Right. Yeah. So what changed? Because we were reporting these numbers. Hey, PNC, can you figure out this Zoom and mute your microphone? We've been doing this for like 2 years already. Go ahead, Vince. Sorry about that.
So again, what we do get right away again is whatever is listed on the form, right? So it does say student, but it doesn't necessarily always say what school they go to, or if they're public or private school, or if they're online or in person. So we do get this info, and we are tracking these age groups, and we do have our investigation team who prioritizes searching, these student cases to see if they're in person or online. So most of the detailed kind of data really does come from our investigation team, but we do have eyes, I can say, as soon as they report positive here at the surveillance.
Right. So Vince, I guess just to kind of expand on that is what changed, because before the governor called off face-to-face learning, we were seeing these student cases being reported, and now we're not. So what's the difference?
So the student cases, we're still seeing student cases, right? But then again, it's a little bit harder to think about where is it coming from, right? Is it necessarily in the schools? Well, we wouldn't say it's necessarily in the schools. We actually are seeing that a lot of the student cases are coming from a household exposure, right? So it's really the parents that bring it home, and then they infect the family. Right. And that's what we're really trying to stop, is if we kind of contact these parents, right? If we try and get the adult population and we cut it off from the source, we can really eradicate these student cases from ever popping up, right? So we're really trying to take COVID-19 and we're trying to catch it as soon as possible so we don't bring it home to our families, right? And when we see students, we actually also see even the older individuals are manumco, right? Because our families the dynamic is a little bit complex. We usually have some kids and we also have some older adults as well. So we're really just relying heavily on our containment branch, right, which is our investigation and our monitoring, to really kind of catch COVID right before it spreads.
Vince, so it kind of sounds like there's been a change in the policy of reporting these cases. But for example, you say you're not sure if these cases emanated from the school setting, but we know of at least one case where a parent picked up an Ukadu student on Thursday of last week. So given the incubation period, I don't even know how clear it would be. And I'm just wondering why parents got used to these things being reported and now they're not. So what exactly was the change in the policy?
So Vince, I think I can take the question. Chris, Chris, your question is about policy on reporting of school cases, right? And what a child who tested positive in school and was picked up to go home is one. Explain in a nutshell is that going back to the data that Dr. Ann presented, she clearly stated that the ages that are those who are of childbearing age and those who are mobile. So when you're looking at families that are mobile, you're looking at families that have. With the opening of the schools, there's a clear guidance on how, and if the school actually tested an individual and they were positive in school, there's a mechanism for them to do case investigation within the school to identify new cases. But the reasoning behind the school reopening plan is to have a layered approach to keeping the school safe. The chances of people getting infected with there, both at home and in the school. But the school reopening plan clearly makes it a safe place for transmission to be very minimal. So the answer to your question is that we are still seeing cases within the community that also has this school age kids. But what we've not identified is an outbreak in any school or a high number of cases in these schools. And we have this layered approach that we're using to keep the schools safe. So I think we should let it go. You know, like we should let the preventive measures that we have in place continue to go. You know, like we have a system that is actually set out to protect the individuals from getting infected. We also have the guidance to quickly identify those who exhibit symptoms and also to cut off transmission. I think the have structures in place to minimize transmission in schools.
Yeah.
So thank you.
Chima, the reason why.
I also wanted to add as well that, the fact that we report a positive case, a student testing positive, does not necessarily automatically mean that the transmission occurred in the school.
No, I know, Janella. I'm just saying that we were reporting these numbers before the governor called off face-to-face instruction, and people got used to. It would take Sabrina a minute to read off all the student positives and the schools they go to, and now we're just not reporting it. But what I'm getting from you, Chima, is that unless they test positive at the school setting, we're not going to identify students who are positive by what school they go to. Is that the change in the policy? Because obviously something changed here, and we just don't know. I'd like to just ask how many students have tested positive since face-to-face return.
And Vince just mentioned to you that when the individuals complete the PUI forms, they do not write the names of the schools in those PUI forms. But the investigation team actually goes another step to find out those schools. And he said he reports this on Fridays. Today is Thursday, so tomorrow is Friday. So when they complete that investigation and get those schools, they'll be able to report them on Friday. So I think that was what he clearly stated.
Okay.
Thank you.
Thank you, Chima. Thank you, Vince. Thank you, Janella.
Thank you, Chris. And I'll just go back to PNC's Don Sulat. I know earlier you said you didn't have any questions, but did you want to ask a question? I'll just give you another opportunity.
Yes, thank you for that. I just wanted to know how long until the COVID antibodies are expressed in the body after a person is exposed to COVID.
What is the question again, Janella? I can't hear. I think.
Sorry, can you hear me now?
Yes, please.
I just want when a person is exposed to COVID, how long until the COVID antibodies are expressed in the body after said exposure?
Maybe Dr. David.
So you're asking about the antibody levels, right? You're not asking about how long could they test positive for COVID, right? Just to clarify.
Both. Actually, that would suffice as well.
Okay, so somebody who's been exposed to COVID, who gets infected with COVID, then goes on to produce antibodies from that natural infection. What has been found in the 1.5 years of experience we have is that after about 90 days, those antibody levels start going down. And that's the basis for the recommendation that even if you've been infected with COVID, that you consider getting vaccinated, and the timing of the vaccine is about 90 days after the infection. So I wonder, is this the answer that you were looking for? I just want to clarify that I understood it.
Yes, that works. Thank you so much.
All right, thank you.
Did you have a follow-up question, Doctor?
Yes. Exposed to COVID, is there a message to wait? Would it make a difference for them to wait 3 to 5 days before going to get tested?
Okay, so if you're looking at in two ways, if you're identified as a close contact to someone who has COVID and you are vaccinated, if you look at your time, if we look at the time of your exposure, then it is recommended 5 days after your last exposure to the individual who had COVID. The reason being that the test will be able to detect the COVID virus within that time period, because sometimes people test too early or they test too late. So that time frame is that that infection, that virus from the test. But another explanation would be you could the person who got tested, because at that point, who infected who. But the first person who was identified as the index case will name the people who were in close contact with them. Might develop COVID-like symptoms before the 3 to 5 days. They can still go COVID-like symptoms. So the determination is made based on the time of exposure, the length of exposure, and the time in between, so that you're not testing too early or too late to miss detecting the virus in the test. Expand on this. Thank you.
Okay. Thank you, Chima. Thank you, Don. All right, well, that concludes our question and answer portion. I want to thank all our media partners for joining us today. And also thank you to Dr. Ann, our territorial epidemiologist, Dr. David, our lead epidemiologist for SEOW, and to Chima Mbakwe, our Chief Public Health Officer. Again, we look forward to doing this every week on Thursdays, possibly at the same time, 9 a.m. And if anything changes, I will let our media partners know. And I'll also be sending you all copies of Dr. Ann's presentation. Thank you all and have a good day.
Thank you.
Right on. That was the Department of Public Health and Social Services. That's great. It's going to be a weekly briefing. And I know Janella said at the beginning that they were